afternoon, all the participants. Thank you for staying here until the last session. It's hot as our weather right now. The topic is hot topics in GI in 2025. What is trending, changing, and coming?
So it's our honor to introduce the next two distinguished moderators. The first one is Professor Joto Lin. Professor Lin, I think everybody already knows him already. Professor Lin is a vice superintendent at Ida Hospital in Kaohsiung, Taiwan, and Professor Emeritus at National Taiwan University. He also serves as the honorary president of both the Digestive Endoscopy Society of Taiwan and the Gastroenterological Society of Taiwan. He has made lots of remarkable contributions to the understanding of peptic ulcer disease, H. pylori infection, gastric cancer, and also many other areas of digestive health. And our second moderator is Dr. Rona Lawenko. She earned her Doctor of Medicine from De La Salle University, where she now being a respected clinical instructor and complete advanced training in gastroenterology and gastrointestinal motility, both in Philippines and Malaysia. So please giving a warm welcome to our moderators.
So
Thank you.
The floor is yours.
Thank you. Good afternoon, everyone, esteemed colleagues. So welcome to the session, and it's my privilege to moderate this discussion with Dr. Tom. So to start, let me introduce our first distinguished speaker, Associate Professor Eddie Oy from Singapore. He is renowned for his leadership across the Asia Pacific. He's an expert in inflammatory bowel disease and precision therapy, on top of his role as the president of the Asia Pacific Association of Gastroenterology. He will present Redefining IBD Care, the Rise of Small Molecules and Precision Therapy. So please join me in welcoming our esteemed professor.
Thank you, Mr. Chair. Thank you very much for the nice introduction. Thank you again to our organizers, Professor Ratha-korn, for the opportunity to talk to you about small molecules and perhaps are they redefining IBD care. So these are my disclosures, and in my outline next 18 minutes, I've been told I have 18 minutes, I'll just share a little bit on what currently are the unmet needs in IBD medicine, and what are really the limitations to the current biologics that we have. I'll spend a bit more time talking about the two small molecules, in particular JAK and the S1P modulators. And to show perhaps that with currently these small molecules, I think we are able to redefine patient outcomes a little bit better than previously. So this is an elegant chart to show you that really there are so much management challenges, especially in Asia. And this is a nice cartoon drawn by Joyce Mark from Chinese University, Hong Kong, to tell us that for the longest time, we delay the diagnosis of IBD because we think we have to deal with infections. And finally, when we think we've got a diagnosis, the reality is, can we use the drug that we want? I mean, Michael Camm always used to say, the first drug you use for at least moderate severe disease should be a drug which is potent, a drug which changes outcome and the long-term sequelae. But do we have that? So the problem is, yes, we do, but the cost is prohibitive and it goes on and on and on. So really, the goals now, I mean, when we look after IBD medicine, when I first trained 20 years ago, we'd all have, okay, we do a few blood tests, full blood count, CRP, ESR, and then we have a global sense, the doctor's global sense of whether the disease is quiet or not. But today, that does not hold water. The reality is we have to have objective markers. We need to know at a certain time point, what do we expect in our patient's recovery? And it has to be, obviously, targets like blood tests, stool tests, and even mucosal healing. And we wait a bit longer, we want really even perhaps one day histological healing, and that's all coming. The idea of doing all this is because we want to prevent long-term sequelae. I mean, for ulcerative colitis, you end up with surgery. For Crohn's disease, we know that from luminal disease, we get penetrating disease, we get abscesses, we get stricturing, we get intestinal obstruction, and so on and so forth. And whatever it is, as you can see, the clinicians have a target when they look at the patients have a target of what they want to do in terms of preservation of the quality of life. But at the end, they all come together in the sense that we want a drug that works, we want a drug that works very quickly, and more importantly, when it works, we want the sustenance of that efficacy. And of course, we want it to have mucosal healing because that portends the best outcome for IBD patients, and it has to be safe. What I didn't add is it has to be reasonably approachable to different types of different economies in Asia. So these are the 4 conventional biologics. So when I refer to them, they are our old friends, infliximab, adalimumab, vedolizumab, and ustekinumab. What we're going to talk about today is what's wrong with this current biologics, or what can be better. So right at the top, you will see that these are all the short-term induction rates, and right at the bottom is the maintenance data. But if you look at the first 3, adalimumab, infliximab, vedolizumab, you're really just reaching 30% remission, and the deltas are probably less than that. But the newer biologic, perhaps ustekinumab, shows a bit more, but not quite where we want it. So thankfully, there's another talk, I think, on Saturday that you're going to hear a little bit more about a more precise molecule, the P19 IL-23. But today, I will talk to you about what's wrong with the current biologics and what can we lean on in terms of the small molecules. So anti-TNFs used to be my favorite drug. I played with it 25 years ago in the trials in Boston. And really, the problem with it, even though it's a good drug, there's primary non-response in 30% of patients. And if those patients respond, a year or 2 down the road, they lose their response because of immunogenicity, not forgetting the anti-TNF, at least in infliximab, is 25%, 30% chimeric. And more importantly, if the patient has failed anti-TNF, the other drugs don't work that well. This is a quick snapshot to show you the rundown of biologic use in Korea for 10 years, starting from perhaps 2010 to 2020. You find that they started out with a lot of anti-TNFs right here for both ulcerative colitis and Crohn's, and they switch and they switch and they switch. And right down there, you see now, you're going to see a lot more less use of anti-TNFs, and you're going to see emergence of perhaps at least you're going to see some small molecules coming in, at least for ulcerative colitis. So we know that whatever it is, we have to get the diagnosis, treat the patient very quickly with a powerful drug, because that affects remission and better healing long term. And the data is very clear. Either you take the profile data from Oxford, or you take the Israeli data that shows that if you treat early, but question is how early? The Oxford study is within 2 weeks of diagnosis of Crohn's. The Israeli study is within 3 months. So although we say we must treat early, the reality is we can't afford, not everybody in our Asia Pacific, or at least in Asia, can afford that, or we can reach for those medications because of cost. So we're going to talk to you about patients now. So patient 1 is actually a Thai patient. She lives in Bangkok, and she was diagnosed age 29. Essentially, it was extensive disease, moderately severe. Had treated with adalimumab before. By 2019, the physicians here switched her to vedolizumab. Lasted 9 months and was complicated by a lot of joint pains. Then switched to ustekinumab. So by the time the patient has gone from adalimumab, vedolizumab, ustekinumab by 2022. And then fled again despite on ustekinumab in May 2023. And this was the colonoscopy picture. You can see that this is still Mayo 3 ulcerations and a lot of erythema. And the dose was the standard 90 milligrams every 8 weekly. So then the quandary occurs to us. Do we do something? So the physicians in Bangkok decided, why don't we think about something else? So the drug that we thought about was perhaps now the JAK inhibitors. So the JAK inhibitors, we are familiar with the original tofacitinib. It's a pan-JAK. Pan-JAK means it blocks many JAKs, JAK1, JAK2, JAK3. By that, the efficacy comes from mainly JAK1. You get a lot of side effects from JAK2, which is hematopoietic side effects, and JAK3. So the better drugs like upadacitinib blocks more of the JAK1 and has less issues with JAK2, JAK3. And that in that sense has more potency perhaps and perhaps less side effects. So I think bearing that in mind, we just go through the data. But tofa has revolutionized the way we've treated patients because they're generics. In India, a tablet of tofacitinib is $1. Let's say a patient has very bad ulcerative colitis. The cost of mesalazine, sometimes either pentasal, Celafor, whatever you all have, could be more expensive than the generic tofacitinib. But this is the first data that shows you that it works, be it remission or be it 8-weekly remission or 52-week remission. You find that the delta is quite respectable. More importantly, tofacitinib works for patients who have failed anti-TNF. So there was a tremendous, because by the time patients had a lot of TNF and they have failed, and especially ulcerative colitis, those diseases are very hard to manage. And for patients who have failed anti-TNF, it works. So the only problem with that is that tofacitinib has problems with herpes zoster. And we find that in East Asia, there is somehow a lot more herpes zoster in patients in Korea and Japan. It's very interesting. So we don't know whether it's a polymorphism issue. We don't see that much in India or China, but small East Asia, and this is like they control for the use of vaccination. What's interesting about tofacitinib is this is a nice, elegant study that came out last year that showed that you could use for acute severe ulcerative colitis. How we treat acute severe ulcerative colitis these days, if they're very bad, we give IV steroids. If they fail, we give IV infliximab. However, this one shows that if you combine tofacitinib with steroids for the first 7 days, really you find that a greater response in therapy. And more importantly, after the treatment is stopped, the need for surgery is remarkably low. So this Ajit Stoot study from India. So I think this has shown that because patients in India with acute severe ulcerative colitis cannot afford IV infliximab. So if tofacitinib is $1 and they use a generic one, $1 a tablet, you can imagine, and that rescues the patient with acute severe ulcerative colitis, why not? So I've talked to you about upadacitinib, how it's different from tofacitinib. So it's more potent and obviously has less side effects. This is just to show on the right, the studies which you don't have to know, but more importantly, how we dose upadacitinib when it comes to Thailand. Has it come to Thailand yet? Last I checked, it has not, but it's going to come soon. So for ulcerative colitis, just remember the initial dose is 45 milligrams at 8 weeks, and then you could bring it down to 15 or 30 for the rest of the maintenance dose. This is a bit different from Crohn's, and I'll allude to that. But whatever it is, you see that the delta at 8 weeks for patients is very high. You're going to get at 8 weeks, you're going to find almost 25-30% improved patient going into remission at 8 weeks. And again, it mirrors the same thing. Whether you are had anti-TNF and failed anti-TNF, you are going to have good response with this small molecule. And 52 weeks, you can see the delta again is going to be dramatic at 52%. So 52% remission rate, 52 weeks. If you think back again, I showed you the data for infliximab, adalimumab, ustekinumab. They're all hovering around 30 and 40, and the delta may not be that big anyway. So of course, we know that whether you treat the biologics or not, it doesn't make a difference in terms of outcome. Side effects. Unfortunately, UPA has real side effects with, just like the TOFA group, essentially herpes zoster is something you really have to pay attention to. But interestingly, TOFA has a black box warning on MACE and VTEs, but really we don't see that much, at least in upadacitinib. So back to our patient. So now the patient, May 2023, because there were still Mayo 3 lesions, ustekinumab was accelerated from 8 weekly, which is the current usual regime, to 4 weekly. But unfortunately, she was still not in remission. So then one of the physicians here asked her to come back to Singapore, and that's when we talk about whether should we use a small molecule. So I saw her in November 2023. CRP was still high, 19. Stool calprotectin was still 1,000. So we talked to our options. Shall we add an anti-TNF to the ustekinumab? Shall we add a small molecule to ustekinumab? Or should we use a small molecule alone? And she said, basically, I've had adalimumab, I had vedolizumab, I had ustekinumab. I really don't want any more injections. So then we said, why don't we bite the bullet and then go for a monotherapy and see what happens? So we gave her the conventional dose, upadacitinib 45 milligrams for 2 months, just like how the study was done. But instead of taking down 15 very quickly and knowing that she failed already 3 biologics, we decided to keep a higher dose of 30 milligrams for the next 6 months. And this was our patient, And this was the picture after 28 weeks. You can find that really it was Mayo 0. I mean, it was incredible. The patient had a dramatic change. Previously, she was going 5 times a day. Hemoglobin was 10, and now she's constipated. The CRP is normal. The stool calpro is just 38. But not all small molecules are the same. Not all JAKs are the same. So the tofacitinib on one side, octave study, you have filgotinib, which we don't use that much, and ustekinumab, and upadacitinib. So you find the delta is most dramatic in upadacitinib. So really, not all JAKs are the same, so you just have to bear that in mind, but some are more potent, but you must respect the fact that there are side effects. So if tofacitinib can rescue acute severe ulcerative colitis, why not UPA? So this is a nice study from Jacob Bergen from Brisbane and Choon. I'm sure you may have heard them coming to talk about IUS. They're the IUS gospel leaders. So they've shown that even upadacitinib can be used as rescue therapy for acute severe ulcerative colitis. And you're going to get more data coming out from various countries who are using upada now. So it is a Crohn's disease program, just to more important to tell you that the dose is a bit different. If we use 45 for the first 2 months and we use 30 or 15 for the rest, this one requires you use 45 milligrams, which is high dose for 3 to 6 months for Crohn's disease. Obviously, because the load of the inflammatory problem is higher, and I think you need a higher degree of immunosuppression at high dose at the beginning. But these patients are very hard to treat. I mean, you could look at the duration of disease. This is a snapshot to show you that you don't have to look at the fine print, but essentially they are like 8-9 years of disease. And more importantly, they all have failed many, many biologics. But notwithstanding that, you could see that in these patients, we already have long duration of disease, multiply failed biologics. You can find that there's separation of the curve in terms of symptomatic relief, 3 to 5 days out from using the drug. So this is very dramatic. This answer comes back to the first point that if you want to choose a drug, you want a drug that gives the patient immediate relief or as quickly a relief as possible. And you find that here, week 12 are all the short-term data, induction, and week 52, you find that I think you're approaching very high numbers for Crohn's disease for patients who are long duration disease and multiply biologic experience. So, and more importantly, like some of the drugs like ustekinumab, vedolizumab don't really help with extraintestinal manifestations, but upada really helps with arthropathy. In fact, the rheumatologists have been using upada for the longest of time. So is dermatologists. So I always allude to the wonderful experience of our colleagues, the rheumatologists and the dermatologists. They are the ones who've been using these drugs, and we are learning from them and adopting it into our GI armamentarium. Interestingly, we always ask because we have patients who have Crohn's disease and perianal disease. Interestingly, we have some data to show at least at the induction period, at week 12, when the dose is high at 45 milligrams, there are some improvement or complete resolution in draining perianal fistulas. So, but we don't see that once we got to week 52. And the reason I will tell you is my speculation is that induction period, you are using 45 milligrams. And for maintenance, you're dropping them to 30 or 15. And that's not enough for perianal disease. So, but whatever it is, just remember that JAK, unfortunately, is a drug that we don't use for patients who are pregnant. I think there is a bit of small anecdotal data that's come out from Uma Devan and I think the Piano Registry that shows that if a patient on upada, be it for whatever indications, have been exposed, they actually have quite significant, no increase in live births which are abnormal. But at this point, we're not able to say that you're to try to have children when you're Upada. But the study does show that occasionally we tell our patients on Upada, please don't get pregnant, but they do. So what do you do with these patients? At least we show them that they have a choice. If they want to keep the pregnancy, it's probably going to be okay. So this is another patient that just reminds us, I'm finishing, to show that patients on Upada, just remember that we also rescued them on patients who are, when they're on therapy, steroids, azathioprine. This was very bad disease, still Mayo 3, ulcerated. But we get them upadacitinib, and you can see the dramatic Mayo 0 response. Unfortunately, herpes zoster is a problem. So you can see that all the drugs we use or play, including steroids, do reactivate herpes zoster. So the dosing is important. A higher dose will really bring about greater risk of herpes zoster. And more importantly, I think previous biologic use or steroids or older patients are always predisposed. So I'm going to go quickly and talk about S1P. And we know there are two types. Just to share that ozanimod is one. But really, you look at the 52-week efficacy rate, the delta is not so impressive, to say the least. But if you look at etrasimod is another S1P modulator inhibitors. This is a treat to 52 weeks. You find that the delta is better for etrasimod. But whatever it is, what I'm trying to show is that although it is effective, etrasimod is the first study the first drug they did not exclude proctitis and ulcerative colitis study, that there is a niche for this safer S1P. Because the JAK inhibitors have a MACE black box. Technically, if you're using for older patients, the S1P modulators, when it comes to Thailand, does not have that MACE or VTE issues if you're worried about our older patients. So I think they serve different niches, for our different populations, and that's good. Just to show you how the JAK1s have been variously approved across many, many indications. And this is the last slide to show you that the clinical response rate, when you compare the anti-TNFs, the P40, IL-12/23, and you compare them with the JAK inhibitors, you find that upadacitinib right here really is quite superior and as good as the original anti-TNFs for ulcerative colitis. So I'm just going to stop here and ask for questions if there are any.
Thank you, Doctor.
Yes, sir. Eddie, thank you so much for your fascinating talk. So in the current practice, I believe that biologics still have a partial efficacies and the safety concerns. In which clinical characteristic you use the biologics or the small molecule in the patients with the moderate to severe IBD?
Okay, so you're talking about biologics and small molecule, which one do you reach for? Okay, so it has to be individualized. I will take it this way. Which patients need to go into remission quick? And more important, if they go into remission quick, they stay in remission for a long time. So if I can, for ulcerative colitis, I almost will reach for a small molecule now, better than a biologic, because of the ease of accessibility of just one tablet a day, provided they are younger, meaning between age 18 to 55 or 60. When they're older, I worry about the VTE MACE, although we don't see it so much in Upada as opposed to tofacitinib. Yeah. For Crohn's, it's a different story. If you ask me 6 months ago, I would say I would still go for a biologic, which is all we had was the IL-12/23, which is ustekinumab. But today, as I saw walking in, there is the P19 IL-23. That's going to change a bit. I believe that small molecules are not so good for Crohn's disease when compared to the P19 that's outside. So now things have changed a bit. And P19, if you extrapolate the safety data from ustekinumab, it's very, very, very safe. And it doesn't have immunogenicity. You don't have a secondary loss of response like anti-TNF.
So I know that you have to straight away to the airport to catch your flight. So thank you so much, and have a safe trip back home.
I'm sorry, because I have to be in Shanghai tomorrow, so I've got to go. Thanks.
Thank you, Professor. So let's all give him a warm round of applause, and we again wish you a safe travel. So our next speaker is Professor Andrew Chan from the US. He's a global expert whose research focuses on the role of gut microbiome in gastrointestinal cancer. So he'll be giving a talk, a very timely talk on colon cancer, what everyone should know. So let's all welcome Professor Dr. Andrew Chan.
Thank you very much for the opportunity to be here. It's always wonderful to come to Thailand and visit with friends and to really have an opportunity to attend such a wonderful meeting. So my topic today is to discuss diet and how that intersects with colorectal cancer risk. And specifically, I'd like to focus on the interaction of diet with the gut microbiome. So just to start, I think we all know that there has been a troubling trend in terms of colorectal cancer rates in young people in the United States. As you can see from this figure, there's been a marked increase in the incidence of colorectal cancer among people younger than 50 that's been emerging over the last several decades, such that now we see in the US that colorectal cancer is a leading cause of cancer death in men younger than the age of 50, and by 2030 it will be the leading cause of cancer death among women younger than the age of 50. And this is definitely a birth cohort effect, such that individuals born after 1955 tend to be the group that's had the substantial increase in risk. So how do we think about the role of the gut microbiome in diet? I think we all understand that there's been a strong association between diet and the gut microbiome. We know that dietary inputs are very, very sensitive. The gut microbiome is very sensitive to dietary inputs. We also know that among cancers, that diet is a very strong risk factor for colorectal cancer. So it stands to reason that the effect of diet on colorectal cancer may be mediated by changes in the gut microbiome. And these are related to pathways that are associated with host metabolism and immunity. So in this review that we published back in 2020, we looked at various aspects of lifestyle in relationship to the gut microbiome and specifically keyed in on specific dietary factors, specifically fiber, red meat, and how they might influence downstream pathways that are associated with colorectal cancer risk. So recently, there's been a lot of very promising data linking the gut microbiome with risk of colorectal cancer. This was a study that we participated in that was led by Nicola Sagata at the University of Trento in Italy, in which he pooled studies which had a large number of gut microbiome sequence data from individuals with colorectal cancer compared to individuals without colorectal cancer. Because of the large number of individuals in this study, we were able to really look carefully at core microbes associated with colorectal cancer. As you can see from this figure, this outlines that there are several different bacteria that are enriched in individuals with colorectal cancer, and there's various bacteria that are enriched in controls, meaning that they are associated with a low risk of colorectal cancer. Some of these bacteria are bacteria that we're quite familiar with, specifically like F. nucleatum, but there are other novel bacteria that have been identified by this study. And looking at cross-classified analyses between different cohorts, you can see there's strong agreement between these different studies that really outline core microbes associated with colorectal cancer. One of the main genetic pathways or molecular pathways that are associated with these various bacteria and colorectal cancer have to do with sulfur and histidine metabolism. Specifically, if you look amongst biological pathways linked with colorectal cancer, you see sulfur and histidine-related pathways are one of the principal pathways linked with colorectal cancer. So it stands to reason that sulfur and the effect of sulfur on the gut microbiome will be something that's very closely linked with colorectal cancer. So to that end, we decided to examine more closely the effect of sulfur metabolism on risk of colorectal cancer. And we know that organic sulfur metabolism by gut bacteria may be a very key mechanism that links a Western diet with colorectal cancer. We know that specifically bacteria that degrade sulfomucins are a key source of inorganic sulfate, and these sulfates are then potentially a cause of genotoxicity in the colon. So what we decided to do was to examine what are the dietary risk factors for sulfur-reducing bacteria in the colon, understanding that sulfur-reducing bacteria are a risk factor for colorectal cancer. So we decided to look for a dietary pattern that promotes the growth of sulfur-reducing bacteria in the gut. And we looked at this within the context of multiple foods and found that specifically foods that are high, like in processed meat, low-calorie beverages, and low-fiber refined grains are linked with a high level of sulfur microbes. And you can see that this potentially could cause genotoxicity in generating a large amount of sulfur hydrogen sulfide, which can cause genotoxicity on the colon. So we examined the effect of a sulfur microbial diet. So what we did is we actually looked at a sulfur microbial diet. In other words, a dietary pattern that links with a higher preponderance of sulfur-reducing microbes in the colon, and examined its association with early onset colorectal adenoma. This was a study led by Long Win, who was a fellow in my group at the time and now is junior faculty at Mass General. And he looked at the association of a sulfur microbial diet with the risk of developing an adenoma younger than the age of 50. We examined in a large cohort of individuals, and men and women enrolled in dietary studies across the US, individuals that were divided up into various quartiles of intake of sulfur microbial diet. So individuals with the highest quartile of intake are the group that had a diet that would predict the highest preponderance of sulfur microbes in the colon. And in this group, compared to those in the lowest quartile, there was a 1.3-fold higher risk of adenoma in individuals younger than the age of 50. In particular, there was an increased risk of tubulovillous or villous adenomas, so the advanced adenomas that are more likely to cause colorectal cancer. So thinking about this in the context of how we think about microbes more broadly, we looked at the effect of a colorectal cancer microbial diet. So this was a recent study that was led by Kai Wang, who was a postdoc in our group, in which he examined a dietary pattern that linked with gut microbiome that would predict risk of colorectal cancer. Specifically, we developed a microbial diet score in our cohort and assessed the diet score in relationship to colorectal cancer in large prospective cohorts enrolled in the United States. Specifically, we looked at colorectal cancer-associated gut microbes in this meta-analysis of multiple colorectal cancer data sets, in which we found that there was a large number of signatures linked with sulfur metabolism and choline degradation. Using this gut microbial score, we then developed a score that would predict the incidence of these microbes in someone's gut microbiome. So this is an example of how the dietary score was comprised. So using reduced rank regression, we found the meats, several different foods, including processed meat, organ meats, and low-calorie drinks, were linked with a higher proportion of microbes in the gut that were linked to colorectal cancer in both men and women, and then looked at this in relationship to colorectal cancer. First of all, we wanted to prove that this microbial diet was actually distinct from a Western dietary score or a prudent dietary score. So looking at dietary patterns, the correlation was actually quite weak. So this was a novel score that links with the development of a microbiome that's associated with colorectal cancer. And what Kai found was that individuals that consumed a diet that was in the highest quintile of microbial diet was linked with a 1.25-fold higher risk of colorectal cancer compared to those in the lowest quintile. What was particularly interesting was to actually examine the effect of this microbial diet score on oncogenic bacteria that were found in the tumors. Specifically, we examined in the tumor tissue whether there was a high expression of specific bacteria linked with colorectal cancer, in particular F. nucleatum, PKS positive E. coli, and ETTBF positive E. coli, enterotoxigenic Bacteroides fragilis. And what we found is that individuals that were in the highest level of F. nucleatum, that this was associated with a 2.5-fold higher risk of developing an F. nucleatum positive tumor, whereas it was not associated with a risk of developing an F. nucleatum negative tumor. In contrast, for PKS E. coli, there was a 1.68-fold higher risk of a PKS positive E. coli positive tumor compared to those in the lowest quintile, but there was no association with PKS positive E. coli tumors that were negative. For ETBF, we saw that there was a 2-fold higher risk of developing ETBF positive tumor where there was no increase in risk of tumors that were negative for ETBF, showing that there was a novel association with the microbiome there. How about other dietary risk factors? Well, we've been particularly interested in ultra-processed food. We know that there's been a marked increase in ultra-processed food across different age groups that's occurred over the last several decades. In fact, now about 60% of daily caloric intake in American adults are associated with ultra-processed food, and we see this in all different age groups. So we've been examining whether ultra-processed food is an emerging risk factor for early onset colorectal cancer. We know that ultra-processed foods are linked with a higher risk of colorectal cancer and neoplasia more broadly. There's also been a link with weight gain, type 2 diabetes, and also fatty liver disease. And ultra-processed food can be classified using the NOVO classification system, in which we examined various foods that are formulated with the use of industrial use ingredients, such as hydrogenated oils and high fructose corn syrup. We know that ultra-processed food intake has increased quite a bit in the US population because they're used to enhance the appeal of foods. They're also designed to improve taste and prolong shelf life, making these foods very, very convenient to eat. So we hypothesize that a higher consumption of ultra-processed food is associated with an increased risk of early onset colorectal cancer precursors. So to examine this specifically, we used data from the Nurses' Health Study 2, which is a large cohort of women who reflect a birth cohort that has been shown that, to have a rise in early onset colorectal cancer. Specifically among women in the Nurses' Health Study 2 underwent colonoscopy, we found that ultra-processed food was associated with the risk of an early onset adenoma. And this is data that was led by Chen Wang, who is a postdoc in our group, and is currently in press at JAMA Oncology. And what we found is that individuals in the highest quintile of consumption of ultra-processed food had a 1.4-fold higher risk of developing an early onset colorectal adenoma compared to those in the lowest quintile. In contrast, there was no association with the risk of early onset serrated lesions. And we know that most early onset colorectal cancers are linked to the development of early onset adenoma, suggesting that this is a novel risk factor for the development of early onset cancer in the US population. So how do we translate this into studies that can actually move the needle in terms of causality? So we also look to animal data to understand better the causal association of these various diets with PKS positive E. coli related tumors and other tumors that are linked to the gut microbiome. Specifically, this animal study that was led by a group in the UK found in Nature Microbiology that inulin fiber actually suppresses E. coli that are PKS positive, and these are PKS E. coli that can cause DNA damage and tumors in mice. And as you can see in this mouse model, the mice that were fed a low-fiber diet are actually going to develop a higher prevalence of colobactin-producing PKS positive E. coli that drives the development of colonic polyps. However, if you give these mice inulin fiber, you can suppress the PKS positive E. coli and suppress this gut damage. So how do we then translate this into a human study? So we've been working on how to potentially do this within the context of a human intervention study. Now, there are already observational studies that actually echo the mouse data. There are two large observational cohorts that have been shown that people eating less fiber also had lower abundance of this E. coli. People that ate more fiber had less gut inflammation and also lower abundance of this PKS positive E. coli. But we actually want to be able to do this in a causal way by looking at this in the context of a randomized control trial. So as part of our Cancer Grand Challenge colorectal cancer team, we designed this study called Eat Fiber, which is called the Eat Well Adapted Trial for Fiber Intervention to Reduce Bowel Cancer Risk in Early Onset. And specifically, we're going to assess whether eating more fiber and a wider variety of fiber from different sources like beans, whole grains, nuts, and seeds actually lowers biomarkers of early onset colorectal cancer risk. And specifically, you want to explore whether there are molecular mechanisms thought to drive early onset colorectal cancer in animal studies that could be found in a human study that uses relevant biological measures. So this will be a study that will be led by Dr. Jordana Bell and Dr. Emily Leeming in the UK as part of our Cancer Grand Challenges team. So here's our study design. We're going to take 100 individuals that enrolled in the famous UK twin study. This is a study that has been ongoing for several decades in which twin pairs in the UK are being followed for various health outcomes. Within the context of this twin study, we'll randomize one twin to one type of diet and another twin to a control diet. One twin specifically will be given a modified UK Eat Well trial, in which we actually increase the intake of beans, whole grains, nuts, and seeds. And the control group will have a basic UK Eat Well diet without an increase in the beans, whole grains, nuts, and seeds. They'll be followed for 12 weeks and also, for 12 months, and they will undergo several different opportunities to be seen in the clinic for biospecimen collection. That will include collection of serum, saliva, urine, and stool, and also examination of gut permeability markers. And our hope is that by doing this randomized study in the context of a group of individuals for whom there is shared genetic background, we'll be able to identify how a high-fiber diet, which induces a healthier gut microbiome, can reduce biomarkers associated with colorectal cancer risk. So hopefully we'll have data from this study available next year at this time. So in conclusion, we know that the gut microbiome mediates the effect of diet on colorectal cancer risk. We also understand that there are key microbes that are associated with colorectal cancer that can be used to characterize dietary patterns associated with risk. Specifically, we can develop dietary risk scores that can be used to actually identify people at high risk and try to identify novel dietary interventions that can be designed based on these microbial biomarkers. And in so doing, we'll be able to potentially develop new opportunities for reducing and reversing some of the troubling trends in the US with respect to risk of early onset colorectal cancer. So with this, I want to acknowledge the members of our group for which this work could not have been possible, specifically my group at Mass General, but also our collaborators at Washington University in St. Louis, Harvard, the MIT Koch Institute. And on the right there is a photo of our team. This is a Grand Challenge team that's been assembled from different countries around the world, including the US, the UK, France, and Italy, and India, to address the early onset challenge. So with that, I appreciate again the opportunity to be here with you and to share with you our data and to discuss more about the importance of thinking about diet and what we eat and how that relates to the microbiome and how that can be used to reduce risk of colorectal cancer. And with that, I am open to questions.
Thank you very much, Dr. Andrew, for that excellent and very interesting talk. So I would like to invite our audience to join the discussion. If you have any questions for our speaker. Okay, so can I ask you a question? So it's very interesting what you talked about the dietary score, the CRC microbial dietary score. So like for us gastroenterologists in Southeast Asia, so how should we apply this in our practice? Like who should benefit, who will benefit most from like screening or using this scoring system?
Scoring system is really to try to identify a dietary pattern that's associated with higher cancer risk and lower cancer risk. And the idea is that we can use this dietary score to develop a diet intervention that can potentially reduce cancer risk, which is sort of the next step in the work, which is why we developed the randomized trial to examine whether a dietary intervention, specifically a high-fiber diet, which is low in ultra-processed food, can actually shift this microbial diet score from high risk to low risk and potentially provide an opportunity to do an intervention in patients that are at particular risk. So it's not used to risk stratify people for colon cancer risk. It's really used to guide a dietary intervention to reduce cancer risk.
So more for prevention and
For prevention,
yeah.
exactly.
You mentioned, so out of curiosity, what is like the particular demographic, apart from age in your region, wherein you see the increased early onset colon cancer? I mean, in terms of ethnicity, gender?
So in the US, most of the increase in risk of early onset cancer is predominantly, so in general, at baseline, African Americans are at higher risk of colorectal cancer more broadly, but the recent trend in risk in people younger than the age of 50 that's emerged in the last couple of decades has been predominantly seen in whites. So now that the white Americans are actually sort of approaching the risk of African Americans at younger ages. So it seems to be fairly consistent there, and we also see that there is an increasing risk among Alaska Natives and Native American populations too. So you know, it's been mostly in men, but now it's catching up in women as well.
How about like family history is still a significant factor?
Yeah, so family history has been, it's associated with about a twofold higher risk of colorectal cancer more broadly. Whether that identifies, you know, people at particular risk of early onset, you know, I think I think it definitely is still a risk factor for early onset, but it's not explaining the change in the epidemiology in the last several decades. The association of family risk with early onset disease has sort of stayed stable over time. So we think that the risk of early onset disease is really related to some other environmental or lifestyle factor and not genetics.
In terms of like screening guidelines and like in the US, is it going to change?
Yeah, so screening in the US, you know, had been for several decades recommended for people over the age of 50. And then in 2018, the American Cancer Society recommended that we reduce the screening age to 45, and then other expert bodies, you know, followed that recommendation, so that by 2022, it was pretty much universally recommended that anyone over the age of 45 be screened in the US. There isn't really been a push to lower the screening age any further because of the resources that would be involved in sort of doing that. So the US, you know, has been sort of one of the first countries to recommend dropping the screening age from 50, but other countries have been following suit. So I know Taiwan, for example, recently reduced their screening age to 45 as well. And I think that there may be some other countries that will do so in the future. I think Australia is thinking about it in addition to Taiwan. I don't know about other countries, but I think there's been a general push to lower it to probably 45. I don't think it'll go much lower than 45.
So go ahead.
Thank you for a nice talk. Would you recommend to take some probiotics to prevent colorectal cancer in the early onset?
Yeah, so probiotics are interesting. It's been studied in a limited way, and the probiotic intervention studies have not shown much promise yet, but it's hard to know whether it's because of the formulation that's been studied or whether it's because the probiotics are not able to durably change the microbiome in a way that allows people to sort of sustain a healthy microbiome. And with cancer in particular, we know that it's a relatively slow-growing process. So individuals who you know, take a probiotic really need to take it for a sustained way, and we need to actually see a pretty sustained change in the microbiome for us to really believe that it's going to shift risk. Because as we all know, the development of colorectal cancer is probably something that takes on the order of 5 to 10 years at least. So you would have to imagine that you'd be able to sustain a microbiome change over that period of time, and it's not clear whether probiotics can do that, as opposed to something like diet, where if we hopefully can sustain a relatively healthy diet over time, that can be something that can shift someone's microbiome in a positive direction.
Thank you very much, Dr. Andrew. And so let's all give him a warm round of applause. And
now we are moving to the last two speakers. You know that the speaker, you must know him very much, but I have to reintroduce again because that he has a long list of the CV. And Professor Vilaichone was currently is the professor of medicine in gastroenterological and the department medicine, Samashet, University in Thailand, and also he is the chief of the FMT Center, the same university. And you know that he was the secretary of ASEAN Stomach and Microbiota and the Study Group, ASMG, and also the scientific chairman of ASEAN Gastro International Conference 2024 and 2025. Today, we are more than happy to have his speech. The topic is the gut reset, FMT changing internal medicine practice. Professor Vilaichone, please.
Thank you so much, Professor Lin, for your introduction. So my talk gonna touch on the gut resets and how fecal microbiota transplantations is changing the internal medicines practice. I believe that after you got to listen to my talks, maybe you change some idea about the microbiota and the FMT. So what is the gut microbiota? This is a complex ecosystems. It might be the forgotten organs. The human's gut microbiota is a complex community of over 100 trillion microorganisms. And again, Bacteroides and Firmicutes is the major phyla, which confines around 90% of the microbiota in our bodies. Yes, colon contain the highest microbial density, and 99% of the bacteria is from 30 to 40 species. You have to know, we might talk about FMT anymore. So we will go to SOHO. In European regulations, since July last year, they mentioned that the intestinal microbiota is now regulatorily named as a substance of the human's origin or a SOHO. And SOHO-derived medical products are on the new horizon. What is a microbiota transplantation? It can restore the microbial harmonies. For the definitions, the FMT is abstrations of the fecal suspensions from healthy donors into the intestinal tract of the recipients to restore and balance and the function of the gut microbiota. And the goal is to change the dysbiosis to the eubiosis, someone might say the symbiosis, that can restore colonizations, resistance of the healthy microbiota mediated functions. What is the FMT process? Many of you are gonna heard someone's gonna maybe use it before, right? FMT is a rigorous and standardized procedures, and one of the tough process of the FMT is to find the good donors. So in here, if anyone's think that you're a good donor, just let me know, right? We have some things to just like help a lot of people that suffer from many of diseases. For the donors, the selections, to be honest, right now we have only 3 donors in the labs, and one donor might be very, very helpful because it can treat off many things. And our red test donors, as mentioned before, is the ladies that could have a very live longer of the ancestors. So we still need the donors. The second one is the stool collections and preparations. We need a process. After you get the stool donors, from the donors, we have to go to many kinds of tests, including the blood test, the stool test, and also together with the mind testing. And the last, at least, the administrations, I'm going to let you know very soon. The cornerstone, very first one, the FMT, is treatment for the recurrent C. difficile infections. And recurrent difficile infections is the most established and successful indication for the FMT, represents the foundations upon which the entire field of microbiota-based therapeutics has been built. So I believe that no doubt for the treatment of the recurrence of the FMTs anymore. How about the efficacy of the recurrent C. difficile infections? The clinical efficacies can up to 90%. You can have a resolution rate of the recurrent C. diff following after the FMT. And furthermore, it can significantly outperforming standards of the antibiotic therapies. For what is the mechanisms of actions of the FMT in the recurrent C. diff? FMT can restore the gut microbiota abilities to resist the C. diff colonizations and the toxins productions. Let's see what is the current AGA guideline for the FMT in the C. diff. They have evidence-based recommendations in 2024. For the patients with the recurrent C. diff in the immunocompetent adults, I believe that AGA suggests to use. For the mild and moderate immunocompromised host, yes, AGA still suggests to use. And a severe fulminant C. diff infections hospitalized, they still suggest to use. But you have to be very careful when you have to use the FMTs in the patients with immunocompromised host. For the FDA-approved microbiota-based therapy, right now in the US, they can have two companies available. The first one in DDW is mentioned for many times. When you went to DMU even last years, you can see the many booths of the endoscopics, right? Some anti-acid medicines. And now we have two new booths is from the Rebiotas and the Vols. Rebiota is a FMT that we use from the live GSLMs. It's a single dose rectal anesthetics. They can use for the rectal enema response very well. And Vols is a different one. It's a fecal microbiota spore, right? And it's orally administrations, capsule-based therapy. You have to take it for 3 consecutive days. And how much is the price, Professor Sugano? You have know that the FMT capsules, its cost is around $18,000 US. It's very expensive. So it's good, but it's still expensive to use for the FDA-approved indications. What is the new indication for the FMTs? They have a recent publications in Internal Medicine just a few months ago. They demonstrate that the FMT as a first-line therapy for the primary C. diff. Right now, it's not for the recurrent C. diff at all. This is a first phase 3 randomized non-inferiority multi-center trials, more than 100 patients across 20 Norwegian hospitals, and demonstrated that FMT is non-inferior to the vancomycin for treatment, not recurrence, for the primary C. diff infection settle, and clinical response rate is around 60 to 70%, and has a potential to change current practice of the antibiotics therapy to establish FMT as a first-line treatment for the patients with the C. diff infections. So I believe that from this study, we might have a future trends. FMT for the treatment of the primary C. diff may be an indication soon. Recurrent C. diff, refractories, and preventions of the recurrence of these important bacteria. Yes, we also have the experience of FMT in Thailand, in ASEAN country. 4 or 5 years back, we gathered patients, it's 40 years old man, come up with the primary C. diff infections, have 20 times of watery diarrheas, and the stool toxins going to positive for C. diff. And after we used the rectal enema of the FMTs, just 1 day after that, the patient's going to be much better in clinical practice and back home safely. I believe that Professor Navapan sit there. We just did the colonoscopy for the refractory C. diff also, and it still respond very well, even with a single treatment. For FMT of the IBD, this is a different story. They have some factor that can have influence the outcome, just like a donor selections. Paul Moyoides from McMaster's, they identify that you might have to get the right donors. Not every donors can be donors, the treatment for the IBD. The second one is depend on the recipient disease state and severity, and it might be related to the FMT protocol, single versus multiple, and what is the best route. When we talk about the IBD, it's still very interesting. What is the best route that we can use for treatment of the IBD is going to be response very well. They have the studies for the FMT since 2015, and they have a variations response around 30 to 50%. Yes, anyhow, so when we back to reviews of the one of the best reviews of the microbiomes-based therapeutics just published in the Lancet Gastro last year, they mentioned that if successful, FMT will provide a powerful approach even with or without immunomodulators, or even without the biologics, or even the small molecules for the IBD patients. And what is the best route when we want to use the FMT? The best route for the FMT for the IBD might be the capsules. FMT for the IBS, yes, IBS is a different story. It's not a chronic inflammation. It may be related to the gut-brain. Right now, we have to say the gut-brain microbiota connections, and the clinical evidence, to be honest, is mixed, but it seems like a promising. FMT in the IBS, what is the predictor of the response? Yes, they have a key predictors for the treatment response. The first one going to be the delivery routes. Endoscopy delivery appears to more effective than the oral capsules. When you talk about the IBS patient, in not only achieve the symptoms, but also improvement of the microbiota engulfments. And the baseline diversity, you have to know that baseline diversity is with the alpha or beta diversity is one of the important things. If the patients have the baseline microbial diversity, it's not very good. So it means that they have more room to have a greater benefits than the patients have a good diversity before. And similar to the IBDs, AGA seems like confines that IBS might be needs the clinical trial. When we talk about the IBS, what is the good clinical just like a landmark study from Elsa Hiss from Norway. They done the study published in Guts 4 or 5 years back. They randomized 165 patients with IBS to receive the placebo FMT 30 grams and 60 grams and monitor for 3 months. And the baseline is not so different. You can see that the IBS SSS, the abdominal symptoms, and the IBS quality of life is very effective in the patients with FMTs comparing to the patients with received the placebo. Yes, this is our junior colleague, Dr. Natsuda. The good news, she just got a promotion to be an assistant professor in our department, and now she stays with Paul Mayoides in McMaster's. She did a very good study with the cap enema trial. We grabbed the IBS patients for 30, and then the first 10 going to receive the FMT capsule, second 10 FMT with the enema, and the last 10 is going to go for the placebos and monitor for 3 months. You can see that again, IBS SSS, abdominal pain score, and quality of life is significantly better in the patients received with the FMT than the placebo, even with the rectal enemas or the capsules. Yes, and from this study from the APWS a couple of years ago, she received the first runner-up. My goodness, Professor Yamaoka got the first prize at that time. And we just got the publications in Frontier Medicine just a few weeks ago. So yes, Dr. Natsuda, she does a long-term efficacy and safety of the encapsulated FMTs in the patients with the IBS, and we demonstrated that the encapsulated FMTs and FMT via the rectal enemas, yes, have a long-term effects to treatment with patients with IBS, not only for the IBS SSS, but also the abdominal pain score and quality of life. I believe that one of you stay here might be have IBS symptoms, and we not have many medications available, especially for the IBS diarrhea. We have maybe Imodium, right? It's not work very well, not response with the pain, but for our study found that even single treatment, it can respond for a year without the medicines. But we grabbed for the meta-analysis that's just done publications 2-3 years back. They used around almost 500 patients from this 7 RCT and did a meta-analysis and demonstrated that IDS patients may benefit from the FMT where administered with the colonoscopies, and FMT may provide the quality of life better in the patients with the IBS. And again, Elsa Hiss just get a publications 2 to 3 years ago in Gastroenterology. They mentioned that the FMT results in a high response rate with long-standing effect, with only few self-limited side effects, and for at least 3 years. So I think it's going to be, seems like promising, but they can let you know more. Somehow, why not many people is going to be response for all, right? Why some people just respond, why some people is not response well. For the FMT with obesity, sorry about that. In here, everybody in here have a good shape, no obesity at all. Maybe FMT is not for indications for you. FMT for obesity and metabolic syndrome seems like they have some clinical evidence because from the animal models, it seems like can help for the insulin sensitivity, also together with the human study. Yes, one of our junior colleague, Dr. Seth Tachais, he done a study of the FMT in the patients with the metabolic syndrome. This is a DB-RCT trial. He just get a publications in the Journal of Obesity and Metabolic Syndrome just a few weeks ago. They grabbed around 20 patients with the metabolic syndrome. The first 10 going to receive of the FMT via rectal enema, and another 10 going to receive only the placebo and monitor for 3 months. After the FMT treatments for 6 weeks, we use the high-sensitive CRPs and HOMA-IRs along with the hemoglobin A1Cs. It's responds significantly in the patients with the FMT comparing to the placebo. And when we have a meta-analysis, we use around almost 600 patients from the 17 studies. And we demonstrated that not only the hemoglobin A1Cs, the high-sensitive CRP, HOMA-IR scores, the body weight in the obesity patients maybe get the benefits after the FMT treatment. Emerging frontiers for the FMTs and the gut-brain. And again, maybe we have to say about gut-brain microbiota axis. One of the importance, just like we have a clinic, Professor Andrew Chance, Professor Ang, and Professor Ken Sugano. In our GI clinic, believe me, more than half, we got a patient with the functional GI disorders, especially the FDs, the IBS. So this kind of patients going to suffer. and does not sometimes not respond to the treatments very well, and sometimes still have the limitations for the medications to use effectively. So yes, our MC, the Dr. Pubadi, he just got a new study that we're gonna submit very soon about the efficacies and safety of the encapsulated FMT in the patients with the FD. We just get a mentor-mentees award from the Sigma 6 scientific meeting in Malaysia. We gave around 20 patients again. For first 10, we received the FMT encapsulations, and another 10 to receive the placebos, and we monitored it. And we found that the non-abdominal pain score and quality of life is significantly better in the patient's FMT after 3 months of treatment. And interestingly, when we do the microbiota analysis, and again, microbiota analysis is not performed from the stool because we use the stomach disease, right? We use a gastric juice microbiota comparing before and after the treatment in the patients with the functional dyspepsia, and found that in the response test, the microbiota of the recipients is going to go to resemble in the patients with the donor. So I think that this is going to be say why the patients that response because they change the microbiota at all. FMT for the cancers, the immunotherapies is a paradigm shift, and they have a microbiome as a moderator for the cancer treatment. And when we use the FMT, it might be enhancing immunotherapy with the FMT in the clinical evidence. They have a meta-analysis recently used FMT together with the immune checkpoint inhibitors, and the overall response seems like not very good, but anyhow, it's better than to use the ICIs alone. It can come up to 43%. And when we compare to use the monotherapies of anti-PD-1s along with the FMT, seems like combination therapy with the FMT is going to help the treatment with the cancer patients up to 60%, at least in the patients with advanced melanoma. Food, cancers, and microbiota. Food somehow can be medicine. Food somehow can be cancers. Anyhow, they have some FMTs related with enhanced ICIs, or immune checkpoint response, that published in Science a few years ago. And FMT also management of cancer therapy to reduce the side effect and related toxicity. What is the mechanism of FMT for cancer therapies? Because we go to enhance antigen presentations, they increase the T cells infiltrations, they reduce the immunosuppressions, and they can metabolics, reprogrammings, and make the cancer, sometimes even refractory, is gonna go to have a more response. What is the future delivery beyond the colonoscopy? Yes, colonoscopy is good, but you have to, just like an invasive, you have to clean your bowels, right? And sometimes the patients maybe didn't like that because it looked like a little invasive. Enema is good, but because only limited to the distal of the colon. NG, my goodness, they have aspirations. ND, sometimes smelling and aspirations. And capsule, yes, it's good, but it's very expensive. And you still have to make sure that your capsule is going to have a digestion and not breakdowns in the stomach, have to go to the small bowel. In conclusion, the microbiomes as the future medicine. FMTs that have established efficacy for the recurrent C. diff up to 90% of resolution rates. Next is might be for the IBS, for the metabolic syndrome, obesity, the IBD, and the functional GI disease. Mr. Chairman, ladies and gentlemen, I come up with my summary to grasp all of my talk. For the acute illness, just like a C. difficile infection, we can use single treatments and it's donor independence. Even you can use the capsules, you can use the enema, or you can use a colonoscopy. The response is going to be very much. But in the chronic diseases, just like the IBS, just like the IBD, for example, ulcerative colitis, metabolic syndrome, and some kinds of neurological disease, FMT should not single use. It should be a chronic treatment to be integrated with other options. Anyhow, for our experience for FMT for 7 years, and many of the study in Europe and the US center, even I think that Francis Chan did also FMT, we found that it's pretty safe. But in the patients without significantly immunocompromised or much of the intestinal inflammations. So you have to be very careful to use in the patients with the immunocompromised host. We still need the super donors. Again, which one you think you super donor, let me know. I gotta send my fellow to see you very soon, all right? And now we could say that intestinal microbiota is now legally named just like a SOHO or substance of human origins. And again, So whole-derived medical products are now on the new horizons. Thank you so much indeed for your kind attention.
Thank you very much. We open for discussion. Is there any comment or question from our audience? Yes, please.
Please.
Professor Sugano.
Thank you very much for a nice talk. And I didn't realize you are doing a lot of FMTs in your institution. My comment or question is that now in the morning session, we have a lot of good drugs, medications to reduce obesity or metabolic syndrome, like GLP-1 analog, ASG, S-group 2 inhibitors. So, which is much more simpler and safer probably compared to the FMT. So, what do you think about the comparative safety and easiness or simplicity of the treatment between the FMT versus those medications?
So this is good questions. And before I talk, I have to see the pharmaceutical support. Back there, they have many of the GLP-1, GAPs, named just like semaglutines and tirzepatines, right? This is very good questions. I still question why the medication, the FMT, which one is better? And come up with why we not combine it together. Because when you use, I believe that now the GLP-1s and anti-obesity medicine, tirzepatide, semaglutide, come up with the gastroenterologist a lot because we're going to use a patient with MAFOD or MASH. So, but when you treatment with the GLP-1 and GAP, the major important things, they have a lot of side effects, right? When you use it, it's going to have a problem with the gastric emptying times, reflux problem, and nausea, vomiting. That's going to change your microbiota. One of my GI fellows, Dr. Pin, she is an MC also. Now we use a new research topics to combine the GLP-1 or semaglutide together with the FMT and placebos. And we believe that this is a very, very new studies. We like that our objections and hypotheses. We believe that when we use the FMT in the patients, together with the anti-obesity medicines, it can help not only to reduce side effects, but it also can improve your microbiota that change from the medicine. And really hope that might be, we don't know yet, they might have the additional effects. And maybe we invite Andrew Chan as a microbiota specialist to help me to use the microbiota analysis after treatment with a combination therapy.
My second comment is that the rifaximin, I'm not sure if this is available here. It's another way to modify microbiota, and it's also effective in controlling IBS. And what is common compared to the FMT versus rifaximin?
This is a tough question. Rifaximin just get in Thailand many months ago, and we use it in the patients with the hepatic encephalopathies, and also together with the patients with the IBS, the diarrhea type mostly. Rifaximin basically is antibiotic. It's non-absorbable antibiotics, but it's antibiotics, right? So it can disturb your microbiota at all. In any house, if you use to patients with the hepatic encephalopathy, we might use it for quite a short period. Maybe not a problem at all. Dr. Wapan there, she's a motility specialist. But in the patients with IBD, when you have to use the rifaximin, it's kind of antibiotic. We have to use it for quite a little bit long times. So it maybe interferes your microbiota at all. But we don't know yet how much going to be changed. It may be response with the patient with some symptom of the IBD, but in the long term, it may be changed your microbiota.
Because even after stopping rifaximin, that has a carryover effect for maybe 6 months, 6 weeks or something like that. So that might have changed the microbiota that I'm suspecting. So maybe you can do this studies.
I have to find a fellow to do that, right?
And my third comment is that I'm not sure about the name of the person who did it. I think Steve Shriver did it. They actually find that the microbiota filtrate, not the stool itself, was also very effective in controlling IBD. What is the current situation?
May I invite you to be our co-researcher? You give a very good common settles. If you go to walls, it's a Firmicutes spore, right? Somehow we don't have to use the whole stool. But anyhow, to be honest, we don't know it yet. It maybe works for the patient with C. diff infections, but it maybe not works to the other kinds of diseases. So to be honest, right now, we don't know what is the exact mechanisms that FMT going to be works. We believe that when we change the FMT, it can be have change the disperses to the symbiosis. I think two things that we have to know. The first one is engraftment. It doesn't mean that when you change the microbiota, it's going to have a sustain for quite long. You have to go to engraftment. Seems like the liver and lung transplantation. Second one, I think it's going to be important to identify the super donors, and not every donor is going to be good for the disease, especially for the functional GI disorders. If you come up again, Ari, we're going to charge you $50.
Yeah, so thank you for your interesting lecture. So I just technical things about how to keep that our donor still healthy. So you give the like probiotics for this patient, and how to collect the patient from the donor, because because I know there's so many clinical trial that you have done, and also maybe in the future. So how to keep that still healthy, and then to keep everything still good for your patient?
Very good questions. I think that for me, I didn't believe in one bacteria or only a small group of bacteria can change everything. I didn't believe in just like very specific probiotics that can be very helpful. They can help something, but not for all. I believe that we have to change the whole thing, just like to improve overall. Overall, it means when you have to change disperses to symbiosis, you have to think about 2 or 3 things. The group of the bacteria means balancing of the bacteria. To be honest, I not believe they have a bad bugs or good bugs. I think that you can criteria yourself. Just like you have a good thing and bad things. Nothing in the world, when you reach 50 like me, you know that nothing in the world is white or black. We stay in the gray zone. So for me, I think that balancing is one of the important things. It doesn't mean we have to just only one group of bacteria. So the good donors, super donors, is come up because he was born to be a good donor. He doesn't have to get any probiotics, prebiotics. But we have to prove that it's a good donor. We have a microbiota analysis before it going to be a good donor. We have to check the brain. You don't have any just like mad things inside your heads, and your stool should be very good. So please don't have any kind of prickle and any kinds of, sorry about that, raw food, just like a sushi, maybe not a good donor at all.
Thank you.
I believe that we come up, and thank you so much indeed for your kindly attentions.
Thank you so much. Now we are going to move the last but not the least section. The speaker will be Professor Yoshio Yamaoka. He is currently the Vice President of Oita University, Japan, and also the Professor of Department of Environmental and Preventive Medicine in Oita University, and the Professor of Medicine. Also, he is the Professor of Medicine, Gastroenterology, and Hepatology at Baylor College of Medicine, Texas, in United States. Today, he is going to give us a special lecture talking about the Microbiota-Cancer axis, translation, microbial science to practice. Now, we welcome Professor Yoshio Yamaoka.
Okay, thank you. Thank you very much for your attention. Now, this is the last section, so I try to my best to be shortened. But anyways, gastric cancer, of course, H. pylori is very important. But today, especially I focus on the microbiome. But before microbiome, of course, I need to talk about H. pylori. Okay, so there is many evidence factors. Of course, the most important is the Calgary. And in the Calgary, we have the Calgary positive H. pylori and the negative H. pylori. And within the Calgary positive, East Asian type and Western type. And Western type is more important. So this is maybe the consensus. I also believe this is very consensus, so the East Asian type Calgary is very important. This is incidence and the mortality of the gastric cancer in 2022, the worst country in the incidence and the mortality is Mongolia. Then I went to Mongolia to check the H. pylori. So, but somewhat very surprisingly, the East Asian type is only 3%. Most of the 80% are Western type Kyage in Mongolia. And also the Kyage negative cases are very common. But within the Kyage status, Kyage negative is all from only the gastritis. So maybe Kyage is important, but Western type or East Asian type are not so much clear. So usually in Japan, Korea, East Asian type Kyage, and then it's a high risk of inflammation and the gastric cancer. But in Western countries, usually Kyage negative or Western type, and then the weak or moderate inflammation. But in case of Mongolia, even the Kyage negative and Western type, and it's really the inflammation and atrophy is not so strong. However, the incidence and the mortality of the gastric cancer is the highest in the world. So what happens? So that's why there may be probably, of course, the environmental factor is important. So for example, in Mongolia, usually we went to the several places. However, every place's H. pylori infection is almost 80%, is very high. However, incidence of the gastric cancer is very high in Ubus. Okay, so compared to the Ulaanbaatar. Then what is the difference? It's a salt intake. So it's really the salt is very important. So this is correct. How about H. pylori? As you can see, as I said, it's a so-called a little weak type. So maybe a gastric microbiome might be important. So we check it as a microbiome, gastric microbiome in Mongolian population. So this is some other result. So blue color is H. pylori. So usually in the atrophy, and still most of the cases are H. pylori. And however, gradually become the intestinal metaplasia and the gastric cancer, the prevalence of the H. pylori is decreased. So this is also common sense. But in gastric cancer cases, some other interesting result. So in the 5 cases, EE, there Enterococcus. So almost all the microbiome is Enterococcus. And also the 5 cases are Lactobacillus. Usually Lactobacillus is some other good bacteria. Then we check these 2. So we isolate this bacteria. As a result, Enterococcus is really not so bad. However, as Lactobacillus is not so bad, but as an Enterococcus, we we isolate these Enterococcus from the gastric mucosa of the Mongolian samples, and then we check it. So as a result, this bacteria is somewhat induced DNA damage. So currently now we are studying about this causes gastric cancer or not using the animal models. Then next, Indonesia. So I went to Indonesia many places with Professor Alishan and Miftar. So as a result, for example, in the Java, most of the people live in Java. It's age 9, 10. As you can see in Jakarta, around 14%, and also we went to the Shimadam, but no one infected in H. pylori, and also Surabaya, the Miftar's place is also only 6%. So it means in the Java people, only the 5% are infected with H. pylori. However, there are also a lot of symptoms. So there is a lot of gastritis. So again, we also check the gastric microbiome in Indonesian population with Miftar and Dr. Alishan. And then we also check the gastric microbiome in here. So as a result, in the family levels, And the species levels is really, of course, H. pylori positive cases, H. pylori is, of course, predominant. But in the H. pylori negative cases, also there is many bacteria. But this negative cases of this bacteria is also a little different what we found in Mongolia. So it means that microbiome in each places might have the different. And all samples depend on the ethnic group. The microbiome's condition is different. But in H. pylori negative species samples, there is no difference. So the alpha diversity among all samples are significantly different, suggesting that the ethnic group influence the gastric microbiome composition. However, in the H. pylori negative cases, there is no differences. So probably, of course, H. pylori is a stronger effect about compared to the other bacteria. And also, this is only a week ago we published. It's also how about H. pylori and the microbiome. So this is a somewhat small study. However, this is somewhat interesting. The result is H. pylori virulence factors and the microbiome composition is a little linked. For example, the Vilaichone species is very predominant in East as a patient who infected with East Asian type Kage, and also Klebsiella is most common the person who are infected with bacteria H. pylori without bulb or something like this. So currently we are also a little increase the number. However, some other virulence factors of H. pylori and the microbiome are somewhat correlated. And then currently we have several samples. So with Thailand, Bhutan, Cambodia, Bangladesh, Myanmar, Nepal, and Vietnam. And we have around to try to check the positive 30 and negative 30. And this is H. pylori positive cases. This rapid urine test, culture, histology, immunohistochemistry, and the serum antibody, all positive, we call that positive. And all these 5 tests negative, we call that H. pylori negative. And then we check it. So it's a number of the OTS. So in some countries, I'm not sure, it's probably not a contamination. However, for example, in Vietnam, so even the H. pylori, all the tests, 5 tests negative. However, if we use 16S ribosome RNA, sometimes it's a positive. So it's a transient infection, or because we usually change the forceps every time. So I don't think it's a contamination. And also not only from our groups, there is many groups also have even the old test H. pylori looks like negative, but it's some microbiome check H. pylori is positive. So some transient infection might be happened. And it's H. pylori negative cases, there is many bacteria. So the Chow index is higher in H. pylori negative compared to positive. In the positive cases, most of the bacteria in the stomach is H. pylori. And then, so it's 7 countries, it's a PCA analysis. So it looks like it's randomly, but for example, the blue color is from the Bhutan. And only the next country, Nepal, is a component of the microbiome is very different. So probably the microbiome is really different except for H. pylori. So for example, is in purple color is Thailand, and also the Cambodia is a black color. So it's also the neighbored country. However, the composition of the bacteria was very different. So this is also very interesting. So we must study microbiome in each country. And then we also focus a little on Japan. So usually I show this picture every time, so that in Japan the incidence is very high. However, mortality of the gastric cancer is very low. So this is probably in Japan, gastric cancer is found in early stage, and also from 2013, the national insurance cover H. pylori eradication using the insurance, and as a result, accordingly, the gastric cancer deaths in Japan is also decreased. Currently, even less than 40,000. And then this is a very new study in Oita city. This is around 500,000 people living in my city. And in the elementary school, 5th grade elementary school, fortunately in our city, all the elementary school children, we got not urine, but it's a little rare, but we got blood. So that's why we communicate with the Oita City mayor. Unfortunately, the mayor is a doctor, so we decided to check all the 5th grade children to check it. And initially checked by the serum test, and at that time we are a little anxious about which is a threshold. So 3 or 10 or so. So to tell the truth, initially we set up 10, 3. So as a result, around 4,000 people who are checked for the serum test, and as a result, around 400 people are looks like the positive. So I'm a little surprised, but then we, as a second check using the stool antigen test, it's only 22. It means currently in Japan, in the 5th grade, is 10 years old. Only about calculate around 0.6%. It means that less than 1% are now infected in Japan. So currently there is many paper or meta-analysis in the world. Still, I always discuss with one time we have some comment paper letter to the Gastroenterology with Professor Sugano. So the actual incidence of H. pylori in Japan is much less than previously reported. So for example, in the 10 years old, probably only 1%. So then now in Japan, the topic is, so that's why the H. pylori is decreased, and the microbiome, but somewhat interesting is the non-Helicobacter pylori, Helicobacter. So there is many Helicobacter, blah, 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 blah. So especially the Helicobacter suis is currently the hot topic, especially in Japan. So this is some review paper with my group. And H. pylori is usually on the human, and H. suis is usually from the pig. So and also the fairies or something others, especially the Helicobacter suis are thought also to be the cause of the gastritis, maltoma, also the ulcer, and even the gastric cancer. So it's okay. So especially the maltoma. So usually the people who eat the raw pig, and not only the raw pig, maybe it means the raw stomach. So it's not baked very well. So usually these kind of person are easy to be infected. And this is a new study. It's only the humans ago. So this is in the Hokkaido, Tokyo, Nagano, and Okayama. So it's 4 locations. And for the gastric juice or the PCR to check the Helicobacter suis and also non-suis. Usually we call the NHPH, the non-Helicobacter pylori Helicobacter. And the serum, so recently Dr. Rimbara established the method to check the ELISA method to detect Helicobacter suis. and some other questionnaires. And as a result, only 3%. So only 3%. However, in this study also, even adult, H. pylori is also only 3% in Japan now. So previously the H. pylori is a 50% or something. So that's why only we are focusing on H. pylori. But now, especially in Japan, it's only the 3%, and the non-H. pylori H. helicobacter is also 3%. So it means 3% is already somewhat very important. And among them is a 70% Helicobacter suis, and it's a small number, however, all from the male, and also everybody eat pork viscera. And how about a non-Helicobacter suis NHPH? 50% are cat as a pet. So probably from the cat to the human. And endoscopic finding is we call the mark. It's a marble and crack pattern gastritis. Is found in the 93% of Helicobacter suis cases. So something like this, and sometimes it's a nodular. So seems to be the so-called nodular gastritis. Non-cyst cases, or 33% are spotty, some at a red point. So, it's a very difficult to compare, it's distinguish between the H. pylori and this Helicobacter species. And also the somewhat point is this is A is a non-H. pylori Helicobacter, and BC, D is Helicobacters. So it's a kind of the nodular gastritis, and usually in the H. pylori infected nodular gastritis is a nodular is mostly is on the antrum. However, in the non-H. pylori Helicobacter cases, nodular is also up to the lesser curvature of the angle to even the lower body. So probably not only in Japan, so maybe in ASEAN countries, maybe I think that it's gradually the increase in importance of the NHPH. So now we also have a lot of collaboration, and we have now the serum. So now we are trying to check. For example, it's H. Suis is from pig. This means our hypothesis size. Probably if we check in Indonesia, maybe 0% or something like this. So the infection linked to the pork oxygen injection and pet contact, and the detection rate are rising due to the recognition of the endoscopic patterns. So previously, the people are not so aware of this gastritis, but now gradually the people understand this marked gastritis. Especially the Helicobacter suis is the most predominant species of NHPH, and male predominant, suggesting that probably the male usually are a little prefer to eat the raw intestine or something like this. So around 3%, but 3% is not so big number, but it's not so small number. So we must be careful to even from this group, maybe we can check the NHPH. Okay, thank you very much for your attention.
Thank you very much. And we open for discussion. Is there any comment or question? Yes, please.
Yes. Thank you very much for your presentation. I'm Dr. Như from Vietnam. And besides the cause of gastric cancer, such as Helicobacter pylori and non-Helicobacter pylori bacteria, and how about the role of autoimmune gastritis in gastric cancer, and how about the data in Japan now?
So today we only focus on the disease, especially the related gastritis related to bacteria, but also the autoimmune gastritis is also the very big topics. And usually the autoimmune gastritis is little also separate from the non-HPH. And so this is a little different status of the disease. But so the even AIG and also this kind of new gastritis, usually people did not aware. So that's why the if we try to aware, so it's a little increasing. So the AIG is also, but the guideline of the AIG is not much established even in Japan. So, but it's currently increasing.
Being the moderator, I have the good opportunity to ask the last question to Professor Yamaoka, because I was so astonished that you have found the non-H. pylori bacteria, which may be related to the pork or cat. It's a kind of zoonosis. And the most interesting for me is the H. suis. Did it really cause any kind of human disease? And how to detect the H. suis by using any kind of gastric biopsy, or you have some spatial formula to identify this kind of bacteria, and to prove that this kind of zoonosis can cause the human disease, such as gastritis. You have mentioned it. That kind of gastritis is a different type of the nodular gastritis, as we have saw in H. pylori infection. And it is possible to cause gastric cancer.
Okay. So, but currently, this non-HPH is compared to H. pylori is not so much virulent. So, for example, usually if we, are aware of the nodular gastritis in the young, for example, lady, so you must be eradicated or something like this. But in case of the H. suis gastritis, currently there is no report. It's directly developed in the gastric cancer. So, but this is still we don't know. Okay.
Yes. Professor Sugano, please.
I can just briefly comment on the role of the non-HP helicobacters pathogenesis. It is connected to the multiple lymphoma. That was established. And so if you eradicate H. suis, for example, multiple lymphoma will diminish. That's one point. And now their group has established the PCR method to identify H. pylori suis. It is difficult to culture it, but nevertheless, they have recently developed the diagnostic method. That's my comment.
Thank you very much for your complete the study. Tonight, today, we have already finished our job, and I am very great to talk that the symposium this afternoon is coming to close, and some logistic will be announced, okay?